yourself, and then we proceed to our session.
Thank you. Welcome, everyone. I'm Rita Daftari from McGill University and do research in the social sciences in TB and MDR-TB. So very excited to be chairing this session with Sylvia.
Okay, so today we have a very interesting session, and I'm happy to share and very fortunate to be here. And I wanted to say, colleagues, if you wanted to come closer, because I think the idea is really to have a participatory session, so please feel free to join us and be closer. I think we can take most of the session. Our session is called Access to Patient Care is the Right, Privilege, or Ethical Challenges? And we're going to have 9 presentations. So without further delay, let's start with the first presentation. We're going to start with Dr. Nitya Arora. I'm sorry if I say wrong. She's a public health specialist working with tuberculosis for the last 12 years. She works with, she's a now senior technical advisor at the Union Southeast Asia, based in India, in Delhi. So welcome, and please, this is. Thank you, chairs. So you have 10 minutes. I will let you know if you can.
Let me know. Yes. So, okay. Thank you. Very good morning to all of you.
Yes.
Yeah. So this is my presentation. To be or not to be? That's the question. This is an existential question that has, befuddled us since the times of Shakespeare, and it continues. But here the B stands for bedaquiline. And this debate is regarding the access to bedaquiline with the patient's rights on one side and the program's wisdom on the other. Let me tell you a story of an Indian teenager who is affected by TB. Now this girl, she was diagnosed with TB at the age of 13 years in 2011. And she was put on treatment in a private center. After 2 years, she got worse, and it was diagnosed that she had MDR-TB. Then later, again, her condition worsened, and then it was found out that she had XDR-TB. So then she came to the government sector again, and it was in 2014 when at a government center hospital, her DST was done, and she was found to be, her bacteria were found to be resistant to all the 8 drugs for which the DST was done at that time. So she was declared XDR-TB, and treatment was started for her. Again, by May 2015, her condition deteriorated, and she got worse and worse. Happens all the time. So this time she lost confidence in the public sector, and she went to a TB specialist in Mumbai and started getting treatment from there. In the course of time, at the same time, the government of India was rolling out bedaquiline under a conditional access program, and the patient's doctor advised her to go back to the government and ask if she could be put on a bedaquiline-containing regimen. But when she came here, the doctors looked at her report and asked her to undergo again a DST test. The report of the DST test came after several weeks, and there was no result because her sample was contaminated. So she was asked to give another sample and wait for a few more weeks. But she thought she did not have the time because her condition was so bad, and she weighed just 24 kg at that time. She could have died any time. So she thought that she would now take recourse and she would go to the courts, and she filed a case against the program. That is the case we are going to talk about today. Now the government said, the government program officer said that you can't be given bedaquiline because of 2 or 3 factors. One is the bedaquiline is being given only at 6 sites initially in India, and you live in a place which is not serviced by any of these sites. Secondly, we do not have your latest DST report, and on the basis of which we are not able to form an optimal background regimen to go with the bedaquiline-containing treatment. So this case was debated extensively inside and outside the High Court of Delhi and was widely covered by national and international media. So this is the kind of coverage and lot of furore that was created. in all kinds of media, whether it be electronic media or social media or print media. So the papers were full of reports on this case. So, and the media was reporting a lot of voices and perspectives from different agencies, whether it was the patient, her family, her community, TB activists, experts from national and international agencies, and private doctors. Everyone had a say in this case, and it was being reported. So when we look at those voices and we group them, we find that there were a lot of arguments in favor of the girl or in favor of the program, and there were a lot of counter-arguments for the same. So let's see how this debate proceeded. Now let's see what the TB patient and family and activists were saying. They said, patient has the right to life-saving medical treatment no matter where she lives. But the program said that the initial sites are more equipped for monitoring the patients. So it's safer for the patient to live near to the sites. Patient said the delay in treatment with bedaquiline can cause death. But the program said we need additional DST to proceed further. If we don't have DST, we will not go ahead. What was the global TB community saying? At the same time, there were reports of, the latest global TB report was released, and India's contribution to TB burden was very much in news. So the global TB experts said that India's TB problem impacts global health. So Indian program should do something about it, and very fast. Whereas the program again said that we know our country better. We know that caution is needed. We don't have consensus of safety of bedaquiline in Indian settings. We will have a cautious approach. We can't go out and then retrack our steps later. What did the National TB program say? They said that we have protocols and guidelines and they should be strictly followed. Whereas others said, no, you're protecting lives. You have to protect lives, that they should take precedence rather than protecting the drug. Program said we should have controlled access because we want to have drug safety and we want to prevent rapid emergence of resistance. Others said no. By suboptimal use, by only giving it in certain areas and not in the other, to other patients, you have a higher risk of DRTB transmission in the community. Even this patient had been traveling from her native place to Delhi. She traveled at least 15 times in public conveyance, and she could have spread the disease to others while she was commuting. Similarly, we have a large private sector in India, and they said that since patients prefer private facilities, this conditional access should also be extended to private TB specialists. The program said we are just testing it in the public sector under controlled situations. We are not yet ready to move into the private sector. So these were the arguments and counter-arguments that were happening. So what ultimately happened? The case raised several issues from human rights, ethics, and program management perspectives. The court asked for expert opinion and directed the program to review this particular case, whether bedaquiline can be given under the WHO and RNTCP, that is the National TB Program's protocols. Ultimately, a decision was made and the affected person was initiated on a regimen containing bedaquiline as well as delaminate in a private facility, and she's doing well at the moment. She has been on almost 9 months of treatment, and she's culture converted. So she's doing well at the moment. And simultaneously, the NTP has accelerated the scale-up of bedaquiline access throughout the country. So that they were the positive outcomes. So now let me discuss the rights approach to health. What do we mean by the rights approach? The United Nations Universal Declaration of Human Rights in 1948 says that right to standard of living, adequate for health and well-being, is the right of every individual. The Constitution of WHO also says something to the same effect. Even in the Constitution of India, though right to health is not an explicit fundamental right, it is interpreted under the rights to life and personal liberty. Supreme Court has equated the right to life with dignity, right to life as life with dignity, and has introduced right to information, food, health, privacy, and education, etc. Citizens can approach the high courts. There are articles of the constitutions under which the citizens can directly approach the Supreme Court and the high courts whenever they feel that their rights have been infringed upon. They can, if it's something which is affecting public health at large, they can be public interest litigations. And if it is one single person's health which is in question, then certain articles are there. So we see that the Indian judicial system has been active in protection of fundamental rights of citizens, and the judicial activism, because this is something we don't like, but the judicial activism has helped India in balancing the governance overreach on citizens' rights. Whenever these rights have been infringed upon, the government, the judiciary has come to their rescue, and certain cases like those affecting individual diseases, abortions in late pregnancy, euthanasia, and now this case pertaining to tuberculosis are examples to cite here. But at the same time, the courts also understand that all rights, including the fundamental rights, are subject to reasonable restrictions. They are not absolute. So the program managers are bound to face this kind of dilemmas. This happened in India. It will happen in other countries also, when there will be dilemma about retaining the potency of new TB drugs which are being introduced and ensuring individual patient rights. What the solution is to have access to rapid diagnostics, early testing of drug resistance, and proper treatment for everyone having TB. This needs to be accelerated. The access should not remain a privilege. It will be demanded as a right by the patients. So the economic and human cost of delays is high, and India's TB program must be supported with adequate funding to help the country achieve the end TB goals by 2025. Otherwise, the scale-up of new drugs will not happen, the access to new diagnostics will not happen, and there will be questions from such cases from time to time. Thank you very much.
I think we have time for maybe 2 questions. If anyone wants to.
Okay, first of all, thank you very much for your presentation. I'm from Thailand. My name is Dr. Nguyen. I'm working for World Vision Thailand, especially working for the migrants people who are living and working in Thailand. It's not a question, just share the information of our Thailand experiences. Because in Thailand, last 2 years, Global Fund supported the new 2 drugs, bedaquiline and thalidomide. And our chest institute, they introduced 10 MDR TB patients. Within the first 2 months, 2 patients died. This is a very shock, because mortality rate is at 20%. First, our physicians, for our physicians, this is a very new anti-TB drug, because usually Thailand, they use the traditional anti-TB medicines. But later they know that because bedaquiline has a very high cardiotoxicity. It's like in that case, like the expert, from the view of the physician, maybe they worry about the treatment adherence, yes. But from the community perspective, this is for those who are the very privileged, not for the ordinary people. Yes. Maybe they need some more information to go reveal to the public, yes. Because we need to show about our good things and bad things about the bedaquiline. Because a lot of articles from some NGOs who introduce these 2 drugs, usually they are written about the very good things. Yeah.
That is exactly what was the logic of the National TB program. As of now, we have some 690 cases put on bedaquiline in the country, and there have been a total of 200 severe adverse effects reported, out of which 30 persons have died so far. So the sample has to be large to be able to make any, deduce something. Out of 10 patients, if 2 die, we are not able to say much there. So that's what the program also wanted to. That is why the delay was there.
Maybe in the interest of time, we'll move on to the next presentation. Thank you.
Thank you.
Thank you very much. Okay. So moving to the next one, I want to invite Diego Silva, assistant professor at Simon Fraser University, to talk about solidarity in addressing ethical challenges in the implementation of new technologies, a qualitative study. I think my mic wasn't on. But
No, that was a really long name. Sorry, can I borrow that? Thanks, no problem. So thanks very much for having me here today. I thought it was interesting for those of us who were at the plenary meeting this morning. I was kind of surprised by how political, or at least the call for a political movement, that message that was there. It's terrific. I think it bodes well. I think it's where we need to put some of our energy. So as somebody who does ethics, I think part of my role is to provide those who work in the field, those who do policy and practice change, is to equip individuals with the arguments to put forward in order to make sense of how do we bridge that gap within TB funding and whatnot, right? So the idea of global health ethics that was mentioned towards the end of the presentation, one of the presentations, that's terrific. I'm really glad that that was there, and that sort of speaks to the ability to sort of form these normative arguments. So hopefully this project can sort of speak to that. So one of these ideas that is gaining a lot of traction within global health ethics is this idea of solidarity. And this project was to look at some of the ethical issues around the implementation of new technologies, bedaquiline, delaminid, GeneXpert. I'm not going to go into it. I'm assuming everybody here knows more about them than I do. So to begin, I just want to thank the study participants, my co-investigators in the Center for Canadian Institutes for Health Research for funding it. In particular, I want to give a special thanks to Anna Komparek, who's a terrific PhD student who's actually working on this topic in particular. So I'm not going to read this background slide, but this shows, this is a quote from Margaret Chan, the previous Director General. When the NTB strategy was introduced, she said, "I call for intensified global solidarity and action to ensure the success of this transformative NTB strategy." Right? So she kind of threw in this word, right? In the NTB strategy, we see equity, human rights, and ethics, I think. What exactly do those terms mean? Are they meaningful to those who are reading the NTB strategy? So again, how can we start to unpack some of this? So the study purpose was to look at, again, ethical issues around new drugs and diagnostics that were implemented, and to analyze them both through qualitative research and philosophical investigation. So there are some of the methods, 23 interviewees with healthcare workers, advocate, policymakers, and funders. I can go more into that if you're interested. So very briefly, I want to introduce the idea of solidarity as it's sort of spoken about in some of the ethics literature. So there's two schools of thought that I won't bore you with. I'll just kind of speak to some of the common features. So there's this idea of solidarity being pro-social and relational. So fundamentally, it situates the individual vis-a-vis his or her community and the rights and responsibilities of that individual vis-a-vis the society and vice versa, right? So it's, again, that sort of, it brings up very clearly the idea of the relational. There's an emphasis on commonalities and identifications with others. It recognizes that health and illness are socially embedded, and the idea that it's not just a passive value, right? So two ideas that are often spoken about with relation to solidarity, and I'll speak to this a little bit as the presentation goes on, is this idea of standing up for and standing up with, right? Standing up for those who may lack a voice, those who are in a position of a power imbalance, and standing up with these individuals, with these communities. So there were several themes that came out of the participants themselves when we did the analysis. So one is that it's clear that when we're looking at the implementation of these new technologies, there's a failure in solidarity. So it's a key ethical issue in its own right, we found. And it frames and informs other ethical issues raised by participants. So what that means is that when we talk about risk-benefit, when we're talking about other things that come up in the project, which I'll show you here briefly, solidarity sort of follows through all these conversations, right? It's there either implicitly or explicitly. And moreover, this idea of solidarity seems to provide a normative guidance, right? It tells us how we ought to proceed. And again, thinking back to the keynote earlier this morning, it provides that argument that we can then use along with scientific data, right, when we're making our pitch to politicians, when we're trying to engage with broader society. So there's several indications of failure of solidarity. So the background conditions that we're all familiar with, policies that fail to address significant contextual barriers of access. This speaks to some of the issues of the previous presentation. TB is often invisible. And again, the lack of political will. So I was really happy to hear that word used a few times earlier this morning. So why should we care about TB? Again, there's instrumental reasons, right? This idea of enlightened self-interest. It's in our benefit to care about tuberculosis. And for intrinsic reasons as well, there's a recognition of a common humanity, and we have an obligation to those in positions of need or suffering. So how does solidarity touch on other issues, so risk-benefit? So one of the things we heard is that the risk-benefit profile of bedaquiline delaminid, it's worth it, because if you've got nothing else to go for, if it's a last-ditch drug, and you know what you're getting in terms of morbidity and mortality with XDR, you might as well try it. So where does solidarity fit in? The idea, this quote, again, I'm not going to necessarily read it out, is that why have we gotten to the position, the dire straits position that we're in the first place, right? Why is the pipeline so dry, right? And it speaks to, again, this failure of solidarity, this failure to identify with other individuals more broadly. It also speaks to the idea of power imbalances. So this was an issue that came up over and over again. So that when we're trying to implement these new technologies, you have those in positions of powers that dictate upon those in positions of lacking power how these technologies are going to be used, even though those on the ground who often lack the political strength are the ones that have to deal with the consequences of policy. So it calls on to reconceive relationships. So to move from standing with persons who are vulnerable to standing with and not for, right? So this idea of standing up with. And I will read this quote because I think it's actually quite good. Charity is not a substitute for equity or justice. And a donation program, so this was around bedaquiline, while good for the 30,000 people who can get in the first 4 years, doesn't solve the bigger equity issues. The fact that bedaquiline is going to be likely priced too high, right? So the idea here is that when we go to governments and make this idea of, listen, you have to pay attention to tuberculosis, it's not a matter of charity, right? If it's a matter of charity, a person can ignore whether or not to do that certain thing. But if it's a moral obligation, if it's a justice obligation, then the person has to do that thing, right? We have that imperative to actually move forward towards trying to address these bigger social issues. There was a lot of talk about advocacy, and again, this idea of solidarity going through advocacy. So it was seen as a first step to raising awareness to lay foundations for identifying persons with TB. There was the idea that everyone ought to be an advocate. Again, this morning's addresses kind of spoke to that a little bit, but I thought it could have been made much more explicitly, but I'll take it for now. Thank you. And clearly, and most importantly, this idea of persons with TB and effective communities being at the center. That when we're developing technology, when we're implementing, right, that we ought to begin with the end in mind, right? We have to engage with patients and communities from the very beginning and all the way through our advocacy for policy change itself. So in conclusion, solidarity provides a descriptive and analytical framework. So in another sense, it provides a very specific type of argument that can be made alongside arguments of equity and justice towards why we have this obligation to actually get moving, finally and once and for all, on tuberculosis. It's intrinsically important to TB care, but it's also instrumentally important. So if we're not doing it for others who are in positions of vulnerability, with the rise of AMR more generally, and with the rise of MNXDR, it's probably beneficial for us in high-income countries to pay really close attention to what's happening. So that's it.
Recognize a few faces.
Hi, I'm Brian Citro from the United States. Thanks, Diego. I was wondering, so you highlighted that one of the three, I forget the gentleman who last night put out three things that need to happen: political will, new technologies are increased, better technology, and then also better financing. And so I agree that the political will being in the first place there was really important, but I think it was maybe more spectacular that there was no mention of community or the involvement of people with TB. So how, in kind of looking through the lens of what this ethical approach that you're involved in kind of thinking through and promoting, what are your thoughts on that, the kind of lack of that participation, or that, to me, that speaks to a lack of solidarity if that's not really in the center of what we need to do moving forward?
Yeah, so thanks a lot, Brian, for the question. So my response would be that that speaks to the need for us to think more clearly about what we mean by solidarity and justice. So what you're describing is that standing up for these individuals, right? It's the scientific community being the ones who advocate for. But the lack of patient and community involvement speaks to the not recognizing the need to stand with, right? So that the argument is at least twofold, right? So standing for, great first step. Standing with is where we need to really make headway internally. And for instrumental reasons, I think it'll then, though I don't have empirical evidence, lead to better outcomes, right? Because it is those stories, it's those stories that really capture people. So.
Thank you very much.
Can I just make, sorry, can I just make a comment? I mean, I like your quote about the charity issue, because when you look for this angle, sometimes it's hard to argument and to pitch, for new drugs, because then it's kind of a choice, and people feel like, oh, I don't want to do this or that. So I really appreciate that. I think it was interesting. Yeah.
Thank you.
Yeah. Okay, so moving to the next one, I'd like to invite Anne Muneni. She's a public health nurse working with tuberculosis for the last 7 years. She works with mHealth in Africa and Kenya. So she's here already. Yes, welcome. This is, yeah.
Thank you very much for having me. Okay, so I'll use this.
Can you put the next slide, please? Yeah.
Okay, so mine is not quite on ethics and rights, but it's more on involvement of community health volunteers in finding the missing cases or in case notification in TB. I'd like to acknowledge my colleagues who worked on this with me and the National TB Program. We worked together. Okay. So I work for Amref Health Africa in Kenya, and we are the non-state principal recipient for the Global Fund Tuberculosis Grant. We've been the PR for the last, since 2011, and what we are doing mostly is in community TB, care and prevention. We're working in the entire country in Kenya through 29 sub-recipients. And so part of the activities that we are doing, we work with community health volunteers. So what the community health volunteers do, once we have a patient who is bacteriologically confirmed with TB or a child under 5 who has TB, we have a community health volunteer go to the household, and once they're there, they do health education, they screen the patients, and then they refer those who have symptoms and all children under 5. And so what we've seen, the biggest challenge has been, despite all this work that is going on at the community and all the resources that have been put in, we've not seen a change or much change in the contribution of community health volunteers to case notification. So it remained at 4% for a long time. So we felt that we needed to find out what the issue was, and the key concern was that it might be a documentation issue, because from the reports that we get from our sub-recipients, a lot is going on in the community. And so we were able to look at the data before and then after the intervention. So what was our intervention? We decided to do something really simple, to just have a forum where this data is interrogated and discussed. And so we had the TB nurses meeting with the community health volunteers and the supervisors of the community health volunteers, who are the community health extension workers. And so once they meet, they look at the data, they look at what has been filled by the community health volunteers and compare that with the TB register. And so in the TB register, they look at the column that says who referred this patient and see what that says. And so we had these meetings happen monthly in high burden facilities. And our definition of high burden was those who had 10 or more cases in a month. So that may not be very clear, but these are the forms that are filled by the community health volunteers when they go to the household. And so they have a list of all the patients that they saw, or the presumptive cases that they saw, and anyone who was referred. And so they'd come with this and they compare with the register. So during these meetings, they will discuss how to coordinate the TB activity, the community TB activities better. Then they'd also change any discrepancies that were there under the referred by column. If the person was referred by a CHV and it's indicated as a self-referral or any other kind of referral, then the TB nurse would immediately effect that change. And this eventually is what is reported to the National TB Reporting System. And so we used data from our electronic TB system that we use in Kenya. We have an electronic register for all TB patients. And, this is what we saw. In 2015, we had 4% of patients being referred from the community, referred by CHVs, and then 76% were self-referrals, and about 20% were referrals from other sources. But we saw quite a change in 2016, where the referrals from CHVs in those 106 facilities went up to 10%, and we had the self-referrals going down to 71%, while the others remained fairly constant. So we also noted generally in the entire country in Kenya, the cases went down by about 7%, but despite that, the referrals from CHVs actually went up. And the key thing that was noted from this intervention is that most of the time, patients who are referred from the community by CHVs were documented as self-referrals. And so we continue to encourage that we have CHVs, community health volunteers, looking for these cases because they are in the community and they are trained to do the work. But more has to be done to ensure that whatever they do is well documented. So having these structured forums where CHVs are able to meet with the facility and to look at their data and ensure documentation is done well has proved to be a good intervention and should be scaled up. That is my last slide, I believe. Thank you.
Wow, and you are on time, so we have time for questions. So does anyone want to have questions? I can see a lot of hands. Let's do some gymnastics.
Thanks for the presentation. I believe you have shared a very good data of importance of documentation. Since you, as per your introduction, we came to know that you have worked in mHealth. So what I would suggest, like instead of moving and depending upon and scaling it up for paper documentation to get a contribution of community health volunteers, it's better why not to move to mHealth mobile technology, where you will be having actual complete data where nobody can deny that this referral has been done by community health volunteers. And we have got experience of working in India where we have using mobile technology through which referrals are being done by the community health volunteers, and we can actually prove it also because it's there on the software, it's there on the server. So I think that would be suggestion from my side. However, it's a good intervention and initiative taken by you. Thank you.
I respond to that? Yeah.
Oh, sorry. Yeah, thank you very much. Abdullah Abubakar Sise from Sierra Leone. Thank you for your presentation. I was just wondering how you deal with the issue of confidentiality, because maybe that is why the CHV are not actually, I mean, people are not open up to them to refer cases. And then the other second thing I want to ask, how do the CHV capture issues around loss to follow-up? How do they trace those cases? Thank you.
Okay. So I'll start with the first question on mHealth. At Amref Health Africa, actually, that is one of the innovations that we are pursuing. We've started an mHealth reporting system for CHVs called mJali, and we've piloted it in some counties in Kenya, and possibly in the near future, it's one of the things we hope to pursue to scale up this kind of thing. So yes, it's something that we are actually thinking about. Then the gentleman from Sierra Leone, you asked about confidentiality. So these community health volunteers that we work with, first of all, they are all trained. And part of what they're trained in is the confidentiality. And they're assigned to an area where they're in charge of a number of households, where the household members already know this is the community health volunteer who is who we can talk to in case of anything. So apart from TB, they do other activities that normally they would go to the household to educate about immunization, about family planning. So they are well known to the people. But more importantly, when they come to this meeting, looking at the register, that's why we have the TB nurse and the community health extension worker there with them, because they are not supposed to access the register anyway and make any changes. In terms of tracing of patients who have interrupted treatment or lost to follow-up, that's still something that we do. We support under the Global Fund grant. And basically what happens is, if a patient misses the appointment, even by a day, the TB nurse will contact the CHV through the extension worker and inform them that someone from your area missed the appointment, and so they go to the household and find out what's happening and bring them back. Yeah,
Perfect.
thank
Let's
you.
do one more question, and then we move on.
Hi, I'm Shri from India. Very nice presentation, thank you. I have two things. There is an increase in referrals that you have very well demonstrated. But you also say that the notification has not increased according to the referrals.
Yes.
What could be the reasons? And the second one is, the referrals which are made by community health volunteers are recorded as self-referrals. So this has an implication on the interventions that you have made. Any comment on that?
Okay, so on the first question, yes, the case notification, according to the national data that we've been having in Kenya, has been going down. But maybe you may have heard that we've recently done a prevalence survey, and the results showed that we are actually missing about 40% of cases. So again, now we are working with, we are missing cases, and the cases are not actually going down. And the interventions and strategies that we are having now as a country are geared towards actually increasing those cases. So this may not be quite what we should look at right now with the prevalence survey findings. Then the other question was, oh yeah, the self-referrals. Yes, that was an issue because when the patient is referred by a community health volunteer, they're handed a referral form that they should present once they get to the facility. So what we've seen as the biggest issue is either they don't present the form, so the nurse will just assume this is a self-referral, or the nurse will get the form and not document. And so that's why we had to see what happens after all this documentation has gone into the register. Why don't we interrogate the data further and correct any of these discrepancies? So we are still working on how to ensure the system works as it's supposed to be, that they are recorded initially correctly.
Thank you, Anne. I have one quick comment or question that if you can address. There's a hierarchy of health workers in every country, and I imagine community health volunteers are towards the bottom. So can this sort of work be used to empower and increase their level or their status within this sort of cadre of health workers? I mean, how is this accepted by nurses and doctors and other people up the food chain?
Yeah, that is actually one of the challenges we've had. Having community health volunteers accepted as part of the workforce. And as AMREF, because that is one thing we do, we work with the community, we are currently running a campaign to have the government absorb them as part of the health system. And there is some resistance because people feel they are not as educated as these others. But again, where they are not, there's a huge gap. So we are campaigning on that level that there's a gap they can fill. Yes.
Thank you.
Thank you very much.
Is there Kondwani Mshali in the room? So Mr. Mashali is going to speak about civil society experiences and community engagement. If you want to maybe briefly introduce yourself.
Good morning once again. My name is Kondwani Mshali. I come from Malawi. I work with Action Aid International under the Global Fund Civil Society Grant in collaboration with the National TB Control Program.
I think we need the next presentation, please. Second, I think they are uploading.
My title of my presentation is Civil Society Experiences in Engagement of Communities in the Fight Against TB. So I'll give you a background before I proceed. As we know, TB remains a problem, both in Africa and Malawi specifically. And in 2014, the National TB Control Program had to conduct a national TB prevalence survey. And what happened was it recorded that Malawi has a prevalence of 1,014 per 100,000 as compared to an area estimate of the WHO of, that was 373. So, meaning that we have more than 50% of TB cases undetected, and they're still living in the communities. So, having looked at those results, the National TB Control Program had to look into ways how best we can help in case detection. So one of the ways was to empower communities to help in case detection. So there are many approaches, mainly two approaches, which were employed. The first one was passive case finding, and then active case finding. So in passive case finding, the main approach was through community astute time collection points. That is through community sensitization, identification and recruitment of volunteers, training and provision of enablers to the volunteers. Then after that, the volunteers have to do sample collection and research follow-up, and then referral of clients who need to be referred, who maybe they cannot, the volunteers themselves, they cannot handle. And then at the same time, the volunteers themselves provide treatment adherence support at community level. The second approach was active case finding, or I should say symptomatic house-to-house TB screening. So they're the same volunteers working together with community health workers. So basically what they do is identification of urban and rural hotspots, household listing, and then quarterly screening of households. There's also sample collection and results follow-up. The do also provide adherence support once they visit the households, that is, if they find a case in those households. So, I'll present the results for the period of October to March, October 2016 to March 2017. And this data was generated by Ministry of Health, Joint TB, ART, and PMCT supervision. So, in the period I've mentioned, what has happened is we have managed to establish 1,081 sputum collection points, and who have been provided with enablers and are functional. So 10 volunteers have been trained per each collection point, like giving us a total of 10,810 community volunteers. So in that period, around 2,556 sputum samples were referred for microscopy. And out of that, 288 were confirmed to have TB and were initiated on treatment. And they're also receiving treatment adherence support within the communities by the same volunteers. So this is the background of contribution of case notification, that is by community, through community referrals. So if you can see, in January, between January and March, it was 40, 37, 41, and then in the period which I'm reporting, October to January, March, it increased maybe more than twofold. So from 41 to 170 to 209. And as I'm talking, the trend is still increasing. So maybe next time when coming here, we'll be presenting more indeed. So conclusions and recommendations. There's need for community engagement so that maybe we can have a significant contribution to case detection. There were challenges, for example, inadequate sample transportation mechanisms between communities and microscopy centers, and that has affected the implementation as well. There are also difficulties in identifying literate volunteers in some communities. You know, we need to find someone who is able to read and write at least English and who can be able to document properly. It's also a challenge to identify such type of community health workers. And then there's also need to perfectly establish a connection mechanism between community structures and formal health sectors, as my sister from Kenya alluded, need to link the volunteers and the health workers. And another area where we need to invest is in community supervision, monitoring, and the evaluation. So that was my last slide. Thank you.
Maybe if you can stay here, because there might be some questions, and since I have the mic, I can start with a question. If you, thank you for the presentation. I was just wondering if you explore if there was an improve also for the time from screening to start treatment, if there was also an improvement on that.
Answer now? Okay. Yes. Basically, what happens is once the sample has been screened, the presumptive case, they go with their referral form with the contact of the volunteer and themselves. So what happens is they'll immediately notify the volunteer and then immediately initiate them on treatment, and it's the same volunteer who follows that client at his home and then starts supporting them on treatment adherence and so. So I should say yes, things have improved on time to initiation on treatment. Yes.
Okay, thank you. Do you have any additional question?
Thank you. Thank you for your presentation. Just let me ask you one question. So in terms of financially, so how much did you invest to get that kind of community engagement as a whole grant?
Whatever I'm presenting here is supported by the Global Fund. And for the period of 2 years, we're going to invest around $4 million United States dollars. Yes, $4 million United States dollars. The major portion maybe went into providing enablers for the community health workers. For example, bicycles for transportation, sputum collection boxes, protective wear, something. So a major chunk went through that. But for now, since we have already provided that, we're just like continuing now case detection. Yeah.
Thank you for the excellent presentation. In India, it's not a question, it's basically a comment. In India, through Project Akshaya, where the union is managing a civil society grant for the India TB program, we are also implementing the same strategy with the active case finding and the sputum collection. The point here is that the community volunteer who actually plays a very important role, because they are the people on the grounded, and they are the people going to the house to house. They are also collecting the sputum from the symptomatics. So my comment is that how actually you are trying in your project to retain the community volunteers through proper training, or how do you retain the community volunteers so that they do all the activities? Thank you so much.
Maybe she asked a question, then you can ask.
Fine. Just a brief question regarding costing part itself. As you has mentioned, it was nearly 2,500 sputum collection points. And then from that 2,500 sputum collection points, you got a sputum collection of nearly 1,000, which turns out to be in 6 months just nearly 3, like not even 3 also sputum collection per center. How is it justified, and especially the cost incurred for opening up these sputum collection points, and that too how it is justifiable when in 6 months per center we are just getting through 3 sputum collected? Can you just give an idea how we should actually, whether it's justifiable, because cost-wise maybe you definitely might have incurred some cost in opening up so many 2,500 sputum collection points. Thank you.
Okay, you rephrase that one. Did you want to answer that? Do you want me to rephrase it? I'll answer the first one, then you rephrase the second one.
From what I understand, you're wondering about the cost effectiveness, the yield of TB cases when you've invested quite a bit of money into developing these community access points, but then the yield of TB cases is relatively low. So how do you justify that?
Okay. I'll start with the first question. First of all, it's not for the first time to engage the volunteers. There was a certain time through the TB Care 2 project where they also used the same approach, but we ended up losing a lot of them. One of the ways which have been put in place to retain them is, one, we have to be in touch with them constantly. One of the ways is through regular coordination meetings or review meetings. Secondly, in my country, community members, when you give them a task, like maybe giving them tasks to be like volunteers, it's a prestige to them within the communities, and they feel honored to be part of like the health system, helping their own community members. So apart from that, there are some incentives which are provided. It's not big, but like maybe when they meet during a review or coordination meeting, there are some incentives which are provided. So some of those things, they might be the things which make them stay in the program. On the last question, if you can see, that period is 6 months. It took us a lot of time to identify, train, procure enablers, and provide and then start implementing the week. And in my view, that number, that yield is too big for that period because it's not the actual. It was like you at the same time you are establishing, at the same time you are working. So, but maybe next time when you come and present on the current results now, yes, and we can compare the cost effectiveness. Yeah, but for now, I think that's enough.
Thank you very much.
Welcome.
Okay, so moving to the next presentation, I want to invite Berhain from Afghanistan, who will present his colleagues who couldn't be here to talk about the role of ex-tuberculosis patients' engagement in TB care and control in Afghanistan, data review. Welcome. Do you have the pointer?
Yep.
Yes. So to pass your slides here, you have to, no, and here is to pass the slides.
Thank you, Chair. I've never been to Afghanistan. I might have overpassed the airspace of Afghanistan, where I was supporting Cambodia and Bangladesh. It was unfortunate that we're missing our colleagues from Afghanistan. That's why I'm stepping in to present their presentation. But believe me, I'm among the fans who always say, if an innovative approach is successful in Afghanistan, why not elsewhere? With all the challenges they have, I've been coming to this union conference since 2009, and I'm seeing a lot of papers from Afghanistan, both in oral, posters, and the like. Early in the morning of hours, I went to the poster session to just put some 9 or 8 posters. So I really appreciate, and that's how I became the fan. So the role of ex-tuberculosis TB patients' engagement in TB care and control in Afghanistan. This is a data review. Just to give you a background about it and the challenges to implementation, the purpose was to measure the effectiveness of using ex-TB patients to support case notification and treatment in rural and hard-to-reach areas. It's understood that the population living in Afghanistan's rural areas are at high risk of contracting TB due to a lot of reasons like poor nutrition and ventilation. And the TB case identification and infection prevention remains a challenge as well. So the project, the Challenge TB project, intervened in some areas and established patient associations with members of 145 TB patients. So 10 to 15 ex-TB patients were grouped per group, and these ex-TB patients were trained on TB and encouraged to take up awareness activities. And they were supposed to refer presumptive TB cases for testing to health facilities. And occasionally they provided DOTs as well. So this was supported by quarterly review meetings, monitoring data, capturing tools, and monitoring the TB patient association activities. So what did we learn from the results? In 2016, TB patient associations referred about 1,100 presumptive TB patients, of which 7.8% were diagnosed as bacteriologically TB confirmed cases, and all were put on DOT. When we compare with that of the Health Post, in 2016, nearly 9,000 health posts engaged in those referred a little above 20,000 presumptive TB cases. On average, 2.3 cases were diagnosed with TB with a positivity rate of 5.8%. In this table, you can clearly see that the positivity rate is almost equal. So, in conclusion, TB associations comprised of cured patients are more likely to help others in their community to combat the disease, especially in hard-to-reach areas. Cases diagnosed from presumptive TB cases referred by ex-patients and referred by health posts are comparable. We recommend that the establishment of TB patient associations in other cities in Afghanistan and similar settings in the world. By the way, as management science of health, we have taken a lot of innovative approaches of Afghanistan, like the urban dots model, and TB in prisons, contact tracing, and we have a lot of reports from so many countries. I thank you.
I think we have time for one question.
Thank you so much for presenting on behalf of your colleagues. I have one question about the use of engaging TB survivors, that's like the buzzword, I suppose, to help with diagnosis and supporting patients. And I'm curious if the issue of infection control ever came up in any of this.
Yeah.
I'm a huge advocate of the model.
Yeah, that's a very good question. In my probably second slide, when we try to use these ex-TB patients, so infection control was one of the priority in the training, see? So that way, you don't simply engage them. You need to train them. And you ought to send them with all the precautions. Did I answer your question?
Yeah, thank you.
Thank you.
TB patient coming together and doing some great work. But I just wanted to know, the TB patient association, are they a registered body in Afghanistan? They are registered in the Afghanistan? I don't know the context of Afghanistan. It's like is association registered? They have any official official status as an association? Yeah, maybe. Yeah.
No, they are not officially registered as official association, but they are working under the coverage of the health facility. It is not an official association for example. Yes, it's like a shura. We call it in Afghanistan shura. Yes, shura. Shura means a kind of association, but unofficial association. Yes. Thank you.
Thank you. Any more questions? Thank you very much.
Okay, moving to the next presenter, I would like to invite Dr. Zimin Tet Win from Myanmar, working from Save the Children, to talk about community-based TB care in conflict-affected areas in Myanmar.
Good morning, everyone. I'm Dr. Zimin Tet Win from Save the Children International Myanmar. I'd like to present my abstract on community-based TB care in conflict-affected areas in Myanmar. It is an evaluation study of community-based TB care activities by international non-governmental organizations in the country. First of all, please let me introduce about my country. Myanmar, previously known as Burma, is located in the Southeast Asia region. We have our neighboring countries of Thailand and Laos in the east, India and Bangladesh in the west, and China in the north and northeast. And according to our 2014 census, we have a total population of 51.4 million. And among the public health problems the country has been facing, tuberculosis is a major one. And the WHO Global TB Report 2016 stated that we have estimated national incidence of 365 per 100,000 population, and we still have a gap of 26% in the overall TB case detection. And as one of the strategies to tackle this problem, international non-governmental organizations, along with the national TB program, have been promoting community engagement in TB care activities across their country, including conflict-affected areas. And this study assessed the contributions of these organizations on TB notifications and treatment outcomes to their local TB centers in these areas. And the red color in the map displays the coverage area under this study. And we have a series of insurgency off and on in some parts of the country since we have independence in 1948. And according to Myanmar Peace Monitor, we have conflict zones reported in the country. And among these areas, the study covers the areas we have program implementation. And this is a descriptive analysis of routine programmatic data from 3 INGOs and the National TB program from 16 conflict-affected townships in Myanmar. And the study period was from January to December 2015. During the period, coordinating with the National TB program, the INGOs recruited village health workers to implement community-based TB care activities, such as contacting awareness-raising sessions, identifying and referring patients with presented TB symptoms to local TB centers for diagnosis and treatment, and providing dog supervisions to the patients taking anti-TB treatment, and contact tracing among family members of the patients. And the contribution of these INGOs was calculated as proportions of total TB patients registered at local TB centers in these areas. During the study period, a total of 4,956 patients with representative TB were successfully referred by village health workers to their local TB centers for diagnosis and treatment. And among them, about 32% were diagnosed as having TB and registered for anti-TB treatment, which contributed about 16% of total TB patients notified in these townships. And the contribution by the village health workers to township level TB notification has a variation of 0% to 51%. And from the program perspective, we have several possible explanations to these variations. The first one is the different level of security across the areas, which strongly impact the program implementation, such as disturbing the village health workers network, and or limiting the patient's referral, and also interrupting the patient's follow-up visits. And the other one is the approach of the INGOs, such as the selection criteria of the village health workers and supporting their activities. And also, as a recommendations of the National TB program, these volunteers take responsibility for providing dose supervisions and home-based care to these TB patients by 2 to 3 days per week, but the daily dose was provided by the family members. And the treatment success rate was 90% among patients with all forms of TB, and 82% among TB patients with pathologically confirmed TB. And we have a high childhood TB proportions of 43%, which contributed high portions of patients completed treatment outcomes. And apart from that, these areas were prone to conflicts and high internal migrations, which resulted in the remaining percentage of unsuccessful treatment outcomes. If we look at the treatment success rate among TB patients and adult supervisions of the village health workers, we can see a variations of 67% to 100% based on the local situations of the security and program implementation. And if we look at the treatment success rate among TB patients supported by village health workers, which in this graph is represented by the red color bars, and the treatment success rate of the rest of the TB patients registered at township TB centers, which is the gray color ones, we can see favorable contributions of the village health workers in most of the townships. Still, these areas covered by the village health workers are very remote places, and some of them are politically unstable situations. So maintaining the village health workers network and also trying to achieve the treatment success rate in some of these areas has been challenging. And this, our study was based on the secondary source of the programmatic data, which is subnational level. So we might have certain limitations on the representativeness. As a conclusion, community-based TB care activities, especially recruiting village health workers at the community level and engaging their effort into our patients' care, has shown a significant contribution. It enhanced TB case notification and as well as improved treatment outcomes, even under conflict settings. So as the achievement was variable by townships, we might have a different program approach in different political contexts in order to optimize our contribution to better achievement on TB notifications and treatment outcomes. And we would like to declare that there is no conflict of interest regarding with this study. And thank you very much for your kind attention. Please feel free to ask any questions.
Oh, thank you. Maybe I will start with a question. All your patients were adults? First question, I want to ask if they are all adults. And second, if you find any difference between treatment outcomes between men and women, and if they were children, among children as well. That's my two questions.
So would you like to compare?
I want to ask you first if they are all adults, and second, if you found any difference between treatment outcomes between men, women, and if they were children, if you found any difference. I don't know if you look to this data.
These patients supported by the village health workers are from different age categories. It includes both adults and children, and we don't have a much difference in the outcomes of the our male patients and female patients. Yes.
Thank you. Questions?
Hello, Zinman. Thank you for this great presentation. I'm Chinmay from MSF Mumbai. So I had two questions. One was, you said you had children in this cohort. So how exactly were they diagnosed? How did you get the samples, and what were the difficulties while diagnosing children that you faced? And also, maybe I might have missed, but were all these DSTB patients, or were there also some DRTB patients in this? Clarify. Thank you.
Thank you for your questions. Our volunteer health workers were trained on the symptoms criteria to refer the patients with presentive TB symptoms. But the diagnosis was mainly done by the National TB Program, which is here like the local TB centers in these areas. And we have a referral feedback system, which is like if a volunteer refer one patient to the township health center, to the local TB centers, we have a project steps. We usually follow up whether these patients actually reach to these centers and have like a proper diagnosis or also the treatment. And also the volunteer also report how many presentive TB patients they refer from 1 month. And so the program step can check if there are any discrepancy among the patients referred by the village health workers and the ones reached to the health centers, and also the diagnosis. So the program can give feedback to the volunteer village health workers whether these patients have been diagnosed as TB or not, or whether they have they receive treatment for TB. And for my presentations, all the patients are the drug-sensitive TB patients, but we also have DRTB patients who were diagnosed from the patients referred by the village health workers. But the DRTB management in our country is mainly done by the National TB Program, because the treatment is very long and the patient support is also intensive. So when the patients referred by the village health workers has a criteria to test for the DRTB, drug sensitivity test, the TB centers the TB centers do these diagnoses, and if the patients turn out as a DRTB, we have TB nurse who are trained and specialized for supporting DRTB patients. The patients support their DRTB patients. Yes.
Thank you very much. Thank you. So let's move to the next presentation. I would like to invite Dr. Ganander Malik from India. Yes, if you can brief introduce yourself and talk about school children as TB soldiers play a crucial role to TB epidemic. Yes.
Yeah, thank you. And once again, good morning, everybody. So I'm Gayadhar Malik from India, working with the Union Southeast Asia Office, New Delhi. So basically, I'm working in a state, Central Indian state called Chhattisgarh, and which is primarily with the National TV Program of Government of India and Project Aksha, as my colleague already told, the Global Fund supported TV Aksha program also in the state. So thank you. So this will be my presentation basically on the school children. Actually today I was there in the plenary and I was so much impressed, and also maybe I'll say that it was so overwhelming, also it's disturbing to take two lines from the gentleman who was presenting about Canada, the school children and the issues in Canada. So one line was so impressive. He told there are 4,000 children died in school last year in Canada. 4,000 children, and in a country like Canada. And number two, important statement is told, in 2015, TB rates, it was 270% higher among the non-indigenous people in the country, in a country like Canada. So then you can think of Asia or Africa, whatever, where you have the emerging TB cases. So with this note, I'll continue my presentation. So basically, my topic over here is basically about a systematic implementation of a project activity which was done over a period of time by engaging and involving the school children, basically from standard 6 to standard 10 children. So how they were sensitized, they were given sessions in the schools, and ultimately how these school children became the TV soldiers. We call them TV soldiers, and how for them we achieved a lot of things in a most vulnerable district in the state of Chhattisgarh. Okay, so this is the title, Access to TB Patients Care by Themselves. Is it the right, privilege, or ethical challenge? So my topic over here is school children as TB soldiers played crucial role to control TB epidemic by disseminating messages of symptoms and free treatment among their peers, family members, and neighborhood in the Bastar districts of Chhattisgarh, India. So as you can see, India, and I can show, here is the state Chhattisgarh, and you see this is the district I'm talking, Bastar. So with this background, you can see the southernmost part of the district, which is mostly affected by the local sort of ultras, very much affected developmental activities, including the health things. As you know, India represents 3.75 of India's disease burden, which is almost 11 times that of malaria. And with around 26% of the global burden, TB is leading cause death in the age group of 15 to 45 age groups, as it is known. Despite complete geographic coverage since over a decade, still TB remains undiagnosed, untraceable in most part of the country. So coming to this background, realizing this, though one of the unique method to involve the school children, so these young children have been involved in community mobilization. The district RNTCP. RNTCP means Revised National TB Control Program, the India's brand program, national program. Bastar district engaged the school children in tuberculosis control activities. A well-planned, structured, school-based intervention was designed to sensitize and groom the students to termed as TB soldiers. And ultimately, over the 1 year period of time, we evaluated the intervention success that was achieved in these districts as a pilot, which was later replicated in rest 26 districts of the state. So mostly the schools, we have not taken all the schools, almost 250 schools were taken. Those are mostly vulnerable, hard to reach, marginalized communities. And specifically, as I told, the children from 6th to 10th standards were targeted, identified, and they were trained. And key messages like all the forms of TB, like causative agent of tuberculosis, modes of transmission, diagnosis, cure, all sort of things, including the place of treatment, free availability. All these things were given to the children during different sessions at different schools throughout the year by committed community volunteers and civil society organizations. So, what are the intervention response was? They were, as I told, the children were groomed as TB soldiers through this well-structured communication protocol. Trained community volunteers of local NGOs inform the senior treatment supervisors, those who record the TB treatment cases about the TB symptomatics as reported by the children from time to time on a daily basis, weekly basis. So what we observed, almost all the schools that we targeted and oriented, trained, there is 100% coverage, participation is 100%. Almost that means all the children were 3,652 students, those are sensitized, were engaged and involved in the program. In the process, these children, they identified around 174 symptomatic cases, and they were ultimately reported by the identified trained community volunteers at the school level. Finally, out of these 174 cases, 35 VIPs, as you call, the new spear-positive TB cases were diagnosed from this intervention by the children. So what we learned? Primarily, as you can see, 2/5 of the cases, around, so 40 cases of 100 are detected from their neighborhood, the family and also the neighborhood of the school. And specificity, you can see, it was around 33% because it was a fast intervention. The specificity that we saw, it was around one-third percent, but 33%. And most symptomatic cases were reported by students, although it ran from 6th to 10th, but more than 90% cases were reported and done by the 8th standard, 3 standard children. And as you can see, almost 20% cases by these children were reported on same day, while 40 each were reported within 1 month's time. So the conclusion is that, so this is a planned, low cost, you can say no cost actually, 500 Indian rupees per activity. This was the investment. There is literally no cost per school. And students, as a medium of community mobilization, proved a highly effective strategy to diagnose the TB and treat the cases. Although not fully utilized, sensitizing and engaging school children as TB soldiers has immense potential to reach out to the contact cases and increase awareness among the peers and the unreached many. So this was proved here in this thing. And we recommend that further evidence-based studies recommended for a larger engagement of these small children. And we strongly recommend that there should be a curriculum, official curriculum, a chapter should be there in the school curriculum. And this definitely will help the ambitious plan of India's National Strategic Plan 2018-25 that is planning to eliminate TB. This will be a great channel to achieve this. So these are some of the photos that you can see how the community volunteers, NGOs, and the small children, they're listening, so cute children listening to the TB messages, how they'll be going ahead. And here's some photos, some of the school teachers also, as you can see in some of the slides. So they are explaining one-to-one to some children. So I think that's my slide. So thank you.
Thank you very much. I think we have time for one quick question.
Thank you for the presentation. My name is Benson from Kenya. From the presentation, it's not quite clear, following the training, how the children went about to identify these cases. Were they sitting and just waiting for it by chance, or what exactly did they do? And does that border on issues of child labor?
Sorry?
Child labor.
Okay. So I think I have already given a mention about the district and the district, about the district. So this is a marginalized and hard to reach district. And to answer your first question, so this is, as you can see from my heading, so this was not as like active case finding, this was a creating awareness among the school children. And from the many children that we have trained, around 6,000 children, you can see number of case identification was less than 200. So basically the idea was to create a sensitization awareness of the children, school children, so that they can at least try within their peers, within their family, and within the peers. It's not that they are active case, they go and identify cases like community volunteers, like TB workers or TB staff. So basically, the school children, they have been aware, created awareness, and they go and inform the people. It's not that they catch the TB patient and take to the hospital. And number two, I think this part is very critical and also very interesting question. We didn't try to do that. But I don't think the school children, those who have addressed over here, they are not, because if you can see in India, almost, and particularly this state and this district, this is a tribal district. And government has a lot of like social welfare facilities, benefits, like school benefits. If you are admitting your child in a school, up to 10th standard, you get a lot of access, free uniform, free midday meal, then you have tax. You have, if you're a lady, if he's a girl child, you will be given a bicycle. A lot of benefits are given by the government. So I think I can't say no, but more than 95% you don't find child labor among the school children here, what I told. I think I answered your.
Thank you very much. I think we had one other question, but in the interest of fairness to the next speaker, we're going to move on to introduce Mustafa Shefa from Afghanistan. Thank you. Mr. Mustafa Shefa? Yes, please. Thank you. If you can just briefly introduce yourself, please. Thank you.
Hello, everybody. My name is Mustafa Shefa from Afghanistan. I was working since 2009 till 2017 with Management Sciences for Health Challenge TB project. The presentation is about exploring the effectiveness of community engagement in tuberculosis treatment outcome in Afghanistan. This is a cohort analysis. The objective of this presentation is to explore the treatment outcome of TB patients who got their treatment at community level in Afghanistan under treatment of community health worker, community health supervisor, TB survivors, and other community members who are involved in community TB services provision in Afghanistan. The fragile socioeconomic and health infrastructure in Afghanistan and the incidence of 189 cases per 100,000 population in Afghanistan. The prevalence is 340 cases per 100,000 population. The death rate is 37 deaths per 100,000 population. And the issue is that still the 30% of existing TB cases per year is missing. So the quality of service and the treatment outcome remains as a challenge. So the National TB Program, with massive support of USAID-funded TB projects like TB CAP, TB Care 1, and Challenge TB, launched a community-based intervention in 15 provinces of Afghanistan. In these 15 provinces, 14,000 community health workers and other community members, including ex-TB patients or TB survivors trained on referring the presumptive TB cases to health facilities and to provide treatment to these diagnosed TB patients. When they refer the presumptive TB cases to health facilities, and if they were confirmed as a TB patient, then these community health workers provide the treatment to them. If you see this table as a result, we divided the three categories here. The first one is TB patient under treatment at national level during 2015 was around 30,000, and TB patient under treatment at 15 provinces at health facility level was around 20,000. And TB patients under treatment at community level, either by community health workers or other community members, was around 2,800. The treatment success rate at national level was 87%. At these 15 provinces in health facility was 89%. But if you see the treatment success rate at community level, the TB patients who are receiving their treatment by community was 96%. The TB death rate at national level was 3%. At these 15 provinces, it was 2%, and at community level also was 2%. The treatment failure was 1% at national level, and 1% in 15 provinces, but by community health workers, it was 0. The loss to follow-up patients was 3% at national level, also 3% at 15 provinces, and 2% in those patients who were receiving their treatment by community. The patient not evaluated was 6% at national level, and 5% at 15 provinces level, and 0 at community level. So if we come to conclusion, the community-based DOTS, or this community-based approach, brought TB services to the doorsteps of communities. Afghanistan has a very hard geographical situation and also the cultural situation, so this is the best approach to bring the TB service and the treatment to the doorsteps of patients and their communities. It is a cost-effective and sustainable approach to TB patients to get their treatment, so because they are not traveling to health facility, they are getting their treatment at their doorsteps. It was evident that community and community health workers contributed to early case detection and improved treatment outcome significantly. So we strongly recommend the National TB Program to apply the engagement of community in providing TB services and bring the treatment at the doorsteps of TB patients at their communities through the community members and community health workers, and also the TB survivors approach across the country, because right now this approach is only implementing in 15 provinces of Afghanistan. Thank you.
Thank you very much. I think we probably have time for one question, if anyone. Thank you very much for that. Just to sum up the session, I think we've had some very, very interesting examples of how the community has been engaged, from children to from TB soldiers to community care workers to other forms of community health workers just described. And the results seem quite promising. It would be really interesting to learn about some of the acceptability issues or implementations challenges a little bit more, just to identify identify what is the best context in which these sorts of initiatives can be implemented. I also wanted to sum up the first two presentations, which touched more upon the ethical issues and sort of displayed some really nice arguments and counter arguments around access to drugs, which is, I think, a really hot topic, and also this idea of charity versus justice, and perhaps justice and solidarity are the arguments that will lead us forward, as opposed to relying on just, the goodwill of people and voluntary charity mindset. I don't know if you have any other thoughts. Any final thoughts that somebody from the audience would like to share? Mike? Okay. Thank you very much to all the speakers and to my chair. Thank you.